I would like to do instead of choosing one for the other. This is the per protocol analysis is that called the explanatory trial, a test of biological efficacy analysis. So compliant patients, only analysis, the analysis includes only those patients who comply with the treatment regimen. So this is the compliant patient analysis that we deal with. So on the other hand, let me come back to this as treated analysis later on. That intention to treat analysis includes all randomized patients in the groups to which they were randomly assigned. So this is analyzed as randomized. More of a pragmatic analysis, which has been available in the literature. So now we need to see whether you wanted to have an explanatory trial or efficacy analysis or more of a pragmatic analysis in your study. Now, how am I going to do this two methods when I have a dropout data in my analysis? As treated as that. So for example, if I am allocated to treatment intervention A, but I receive intervention B, so therefore I am put in the group where people received intervention B, even though I was entitled to A. For various reasons, doctors put me in intervention B, so therefore I am in intervention B. So therefore, this is called as treated analysis or garbage analysis. So that's something which we need to discuss. We may not have time to do that kind of discussion now. Let us go by definitions. Say per protocol analysis is something which includes only patients who comply with the treatment. So if I'm A, if I received A, I am included in that. If I switch over to B, then I am not included in the group A analysis. That is something which you need to remember. Okay. And so therefore, efficacy analysis versus the pragmatic analysis, that's something which we need to think about it. I'm not sure whether how serious people are doing as treated analysis in any trials. So this is my experience, what I have got involved in two big studies that we have done both intention to treat analysis and per protocol analysis. Therefore, we need to know how do we organize these numbers to put in the denominator. So this is when you decide the intention to treat analysis here. Use every subject who was randomized according to randomized treatment assignment. Therefore, that means if I'm randomized to A, I will stick on to randomized A arm, even though I am shifted to intervention B. So this is every subject who was randomized according to the randomized treatment assignment. So this is treatment assignment is very important. Even though I have received treatment B, I'm still kept in treatment A. Ignore non-compliance, protocol deviations, withdrawal, and anything that happens after randomization. Completely ignores everything. So therefore, this balances, it honors the randomization principle. Therefore, people wanted to have intention to treat analysis. Because we went with the premise that the randomization gives you equal distribution on both arms. That is guaranteed all through when you do intention to treat analysis. Let us look at this example. Some of you would have seen this example. This is surgery plus ASA, some intervention. This is ASA alone. So you randomize them here. And there are 100 patients who are going to have this, 100 going to have this. However, in this arm, before they started the surgery, 10 have developed stroke. So there are 100 patients who are entitled to get this arm. 10 already developed stroke before they received that intervention. And therefore, the denominator is, if you look at this one, intention treat analysis, hundreds are randomized to that arm, therefore hundreds are kept in the denominator. And so 20 received, 20 had interventions, stroke, therefore 20 is in the numerator. Here it is, on the other hand, the per protocol analysis, that is only 10 received this intervention. Therefore 90 received this intervention. And of them 10 had a stroke. Is that right? Per protocol analysis. So the per protocol analysis as treated, therefore the 10 were developed stroke prior to that intervention. Therefore, they were not included in the denominator. And this is of them 10 had stroke, therefore 10 out of 90 is the proportion. Whereas in this arm, that this is no such things happen. There's no surgery involved here. Therefore, 20 received, 20 had stroke, 20 out of 100 and 20 out of 100 in both methods. Any question? Okay. Let us look at this data. Let me ask you the question. For medical intervention, what should be the denominator for intention to treat? If you have understood this concept, what is the denominator for intention to treat arm for two interventions, medical and surgical? So let me explain this number. Those were randomized to have medical arm. 296 had medical, but of the total, 48 were shifted to surgical, but they were entitled to get medical arm. Total is the denominator. Okay, is that right? Okay. So therefore, here intention to treat, what is the denominator? 344. This is 296 plus 48. That is the denominator. Is that clear? Tell me what is the denominator for per protocol for the medical arm? 296. There's only 296. Yeah, we are talking about medical. So is that right? How many in the as treated analysis? What is the denominator for as treated analysis? Medical. 296 plus 20. Is that clear? Okay. Because as treated means that this is 20 subjects received medical. Even though they were randomized to surgical, but they received medical, 20 received medical. Is that okay? Okay. The next, what should go into the numerator? Is it okay? For intention to treat analysis, how many should be in the numerator? We have discussed about the denominator. What should go into numerator? Okay. 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 Let us look at this. Is that right? 29 out of 373. 373 is the number. Intention to treat analysis. Randomized. How do I get 393? That is 296 plus 48. So this is.
So that includes 27 plus 2 also. So the 27 plus 2 is also, that's the survivors.
27, yeah, total is that. Okay. The number of survivors only. It's not denominator basically. Okay. Is that right? So this is now the surgical arm. This is the number. Do you agree with this number? That is surgical arm, 353, intention to treat analysis, 353 plus 23, 73 plus 24, 21, 394. Is that right? Okay. So because this is 353 plus 20, 373 plus 21. That is the first line is only the survivors.
This one question tells that the deaths are not part of it. So survivors and deaths is it?
No, totally we are talking about how many were allocated to, how many were allocated. There are two lines, one is survivors and the deaths. So put together is a denominator. So this is how we need to decide your analysis. Is it okay? Now, please remember that people like intention to treat analysis and people like per protocol analysis, say efficacy analysis. So therefore, instead of choosing one for other, please do both. This is my advice. So compliance with the treatment. So for ITT analysis, they would be used. So some subjects do not comply with their assignment treatment, for which the ITT analysis is used. Why? So we wanted to stick on to the randomization principle. These are all some of these concepts. Why include non-compliant subject in ITT analysis? Again, this is mostly revolves around this the randomization principle and the concept. So these are all the same concepts coming again and again. This is the compliance. Why include non-compliant subject in ITT analysis? Other considerations are some patients are not fully compliant. Compliant subjects usually have better outcomes than non-compliant subjects. Okay. Let us look at this data. This is the complaint was assessed as less than 80% and more than 80%. This statement says compliant subjects usually have better outcomes than non-compliant subjects, regardless of the treatment. So if you look at this data, the response rate now good compliance is over 80%. In both was 15%. This is also 15%. Let us not discuss about whether it is significant or not. Overall, it is around 15%. The compliance is good. The outcome is good because the compliance is over 80%. But when you look at this non-compliance, this is 24 or 25%. Here it is 28%. So this is poor. So this tells the fact that non-compliants are expected to do poorly as compared to compliant subjects. There is a data. Now, how do you analyze it? As you do a subgroup analysis or whatever, it is up to you. But they have done the subgroup analysis. Let's see what happens. This is about withdrawal from the trial. Some subject chose to end participation before the end of the trial. Both explanatory and ITT analysis, these subjects are problematic. So how do you handle the dropouts? So this is missing information. Outcome is not available with you. How do you handle this? That is where we use missing imputing techniques for missing information. We'll discuss about it later on. Now, how much missing that we should be dealing with the imputation techniques and how much we should ignore? There's a saying that in the clinical trials, the missing should be about 10%, less than 10%. If it is more than 10%, people may not be very happy to do the imputing analysis. Observational studies, somebody says, the person who taught us epidemiology, who told us you can go up to 20% for observational studies, but clinical trials only 10%. Somebody says 30%, 40% is missing in your data, don't try to improve the data. This is Dick Heller from Australia. So therefore, this is the industry people use this LOCF concept, last observation carries forward. So this is, but you have to have sequence of observations. Supposing I have one baseline data and endpoint data, I don't know what to do. Still, you wanted to have the baseline data, put in your endpoint data and do the analysis. That's something we need to discuss it. The LOCF means last observation carried forward. So if I have repeated measures, then I can take this observation and put it here. So if that is something is missing and so on. Is it acceptable? Why should we try to include withdrawals in ITT analysis? Why? Because we wanted to honor that the balance of ITT principle. So withdrawal occurs after randomization and might be treated as related. Because this is the basic principle that anything happens after randomization, it is accountable. So therefore, we wanted to honor that concept. Excluding the subject who withdraw could bias the results. That is true. Often outcome information cannot be obtained on subject who have withdrawn. What to do? So this is therefore how much missing information is available in my data is a concern. So this is the flow chart to say how much information is missing in my study. That is a concept flow chart, you know. Yes, yeah.
In the critical appraisal session, the paper we were allotted had a somewhat, I think 94% completion of follow-up for one arm and around 95, 93, something like that for the other arm. But sir made a comment that it should have been around 99% for it to have been considered maybe satisfactory. But is it not okay to have it within the 10% margin for it to be acceptable?
I mean, this is, I don't know, is there any hard and fast rule available?
No, I'm sure there is no hard and fast rule, but what is the usual acceptable cutoff?
I told you that day one, that day two, or what in my lecture, that the Pune study, the measles aerosolized vaccine study, we have planned 20% dropout. So if it is an ideal study, you run it in your clinic, you always know that where is he coming from. If he doesn't come back to you, then you'll go and reach him and so on and so forth. That is feasible. But when you do a phase 3 big community-based studies, it is very difficult to get 99% follow-up information. So you have to be careful in promising what you do. That is why it is 10% is given to you. And even in a clinical studies, hospital-based studies, 10% is okay, I think. Kant can comment on this.
Yeah, I mean, it's really variable. And it depends on what is acceptable in your area of work. So, and it really also depends on what is the purpose of your trial. Who are you trying to convince? And so if you're trying to convince the government to change policy, you may be required, even though as L.Jeyaseelan says, there's no hard and fast rule, you may be required to have less than 1%. But in most cases, unless you have somebody who is pressuring you for it, 5, 10%, 20%, all of these things are acceptable. They're not great. Ideally, it should be 0, but people realize that it's often impossible to do it. That first trial that I mentioned on the first day, that was the trial of coronary prevention in men. The government had invested $120 million, and they did not want to have a single person missing. That's the only large study I know, close to 4,000 people, that tracked absolutely everybody. They went, nowadays it may have been impossible or unethical to do. These were men 35 to 59. A lot of them had affairs, left their wives, didn't want to pay alimony, were hiding somewhere. They contracted detectives to find them, not to pay alimony, but to see if they had had a heart attack. There was one that was at a clinic in Texas working for Exxon. He was sent to Saudi Arabia to work at Amco there, and he was living in the American compound, behaving like Americans, and he was invited out for dinner to a friend's house. He was stopped on the road. They found alcohol in the trunk of his car. He was put in jail. They found out from his wife in Texas that he was in jail. They contracted a local medical doctor from Saudi Arabia to visit in jail to see if he had had a heart attack, not to get him out. They wanted the outcome. It's all they care about. They got 3,806, 0 loss to follow-up. But nobody does that all the time. This is when they wanted, the government wanted, I don't want any loss to follow-up. So they pay for it.
So how to handle intention to treat analysis? This we have discussed the same concept again. So this is basically that better regarded as a complete trial strategy for design, conduct, and analysis rather than approach to analysis alone. So this is, I meant to say that this is, you just look at the overall trial, whether if I take this as the only principle that I would use to analyze the data, I don't think that is the correct one approach. And decide whether the aim is pragmatic or explanatory. That it has to, I don't know whether it has to be a priori thing and so on and so forth. Mostly the pragmatic is done with the where there is a problem and done with the large number of observations and so. So therefore, we don't do that because ideally that people coming from a medical college situation, facilities and so on, that the pragmatic is not feasible. I don't know whether we say that CMC Vellore is a place where you get all kinds of cases, therefore it is pragmatic. There is a place I was working for, I was helping, Tambaram Hospital, TB Hospital, I heard about it. This is close to Chennai Airport, where they treat TB patients. Therefore, they were in a better position to take a big projects on treating HIV patients as well. So the question was whether we need to do a study in CMC Vellore or we wanted to do a study in Tambaram Hospital, where 40% of the patients were coming from Andhra Pradesh, which they're very poor, and 60% from Tamil Nadu and Karnataka. And every day we used to see 45 new cases of HIV those days in 2004-05 in that hospital. So when you do a study, that is a pragmatic study, not doing a study and claiming it as pragmatic study when you do it in Vellore. So funding agencies wanted to encourage a lot of studies for HIV/AIDS at that time. So this is they decided to do, but the problem is that they did not have good researchers in that hospital. How do we minimize missing responses and so on? This is a great question that we may not be able to address. This is what we discussed about. Include all randomized subjects in the groups in which they are allocated. Investigate the potential effect of missing response. So having investigated, what do you do with that? Now, this goes on and on. This is now why we need to understand what is the reason they are missing and so on and so forth. It's a good idea, but sometimes we may not be able to do it. There's another strategy is called the modified intention to treat analysis. There are genuine reasons why they are missing. Either they did not like the treatment or they could not come to you again, they got transferred and so on and so forth. There are many reasons. In that genuine situation, that how do you handle this? Should we stick on to that the total number as a denominator, or there's a flexibility to alter the denominator in intention to treat analysis. That is how we use modified intention to treat analysis. This is what I'll give you the number where how we have decided the modified intention to treat analysis. We altered the denominator based on what issues. Where some subjects who were randomized or excluded from this analysis based on specific predefined criteria. So therefore, it is not that you should have 300 means 300 patients in the denominator. There's a flexibility here, you exclude them. This is a study which I spoke to you about. The measles study, this is the background and the number which we have studied, 1001, 1004 in each arm. So this is protocol deviations are, say for example, received different vaccine instead of allocated to, there are 4 such subjects. So this study was conducted in 6 sites from Pune, close to Pune outskirts. So when I say that this is a subcutaneous intervention or aerosolized intervention, the nurses misheard about it and wrongly has allocated the treatment. Every evening we get the numbers and tally the numbers. That means that they'll send you the list of how many were allocated to each one of them as against our database, what has been allocated. We found out there are 4 misallocations overall in 2000 subjects studied. Now, therefore, the 4 can be excluded from the analysis. That is a human error, it can happen. You not be very stringent in saying that I should put them in the denominator or whatever. Guardian who withdrew the consent when the baby started crying that she wanted to take the baby out of the center and not to have that vaccination. And so on and so forth. This is so this is a 44 were last follow-up and 2 had measles during this follow-up and so on. These are all the numbers. This we have though that we wanted to honor the principles of randomization, still there are genuine reasons why we should exclude them. We should not include them in the analysis. So that is called modified intention to treat analysis. So therefore, if we see here, so the 41 subjects had specimens that were missing or could not be analyzed at the Pune lab. So therefore, they were excluded from the analysis from the denominator. This is the number which we had totally 1,560 in per protocol analysis, 1,584 in intention to treat analysis. So this is the flow of numbers. The data is truly missing, which means that no value is present, and coded value, but it is something different. It is wrong entries or whatever. And miscoded, meaning that there is a value, but it is wrong. So usually the second one is happening because missing values or the wrong values are entered. This is no value is present. You don't get that information. This is miscoded. I don't know, miscoded is happening. There's the miscoded. There's another area of missing data. This is item missing. The respondent is retained in the study but does not answer all the questions, especially the income and so on, health-related questions, behavior-related questions. Wave missing is respondent is observed at intermittent waves. That is, when he comes for once in 3 months, that is still that the particular area is missing, he is not responding. Dropout, respondent case ceases participation and is never observed again. So you don't get to see the data again. These are all some of these patterns of missing, item missing, wave missing, and dropout missing. This is what Kant touched on day one on missing completely at random and missing at random and missing not at random. Let me give you some examples about it. So data missing at follow-up because the participants were out on call. So randomly he is not available. So when you reach them, he is not available. They are not available for you to provide information, missing completely at random. It is not purposefully avoided, it is random. And missing at random is that data missing at follow-up because high BMI and embarrassment. He also said that, because I am very obese, I do not want to come for the follow-up or contribute any information to the study. That is missing at random. And you said missing not completely at random. This is Kant, do you remember something like that? Missing completely at random, not missing at random, missing at follow-up because the weight gain since last visit. So this is not missing at random. This is, he gained weight between the 2 follow-up period and therefore he did not want to come for the follow-up. Again, it's just because of this embarrassment. Or this one we said because he's obese that he does not want to come and contribute his weight to the study data. So therefore, the missing, we wanted to have something missing completely at random data. It's not related to any reason why he's avoiding giving data or whatever. These are all some of the patterns. And this is for example. This is the HIV/AIDS data, which this is an example. Is nothing to do with the randomized control trials. This is the basically it means that missing information happens at the baseline data very much and at the follow-up. And the 2 different patterns, and we need to see how we are going to estimate this missing value when you have missing at the baseline, missing at the follow-up information, etc. This is monotonically increasing the missing information over the follow-up. So therefore, it's a very serious business. How we need to know how do we handle it. And this is basically a general pattern, missing random at different points that you don't get to see any pattern here. So this is basically the question is, how are we going to impute the data when there is a missing value? This is the purpose of this presentation. So the 2 issues coming out of this missing at random, missing random in the sense is nothing to do with any behavior or whatever. Otherwise, the another pattern is something related to the covariates or the variable which we are studying get involved in the study. So these are all the patterns which are available, not pattern because methods available to impute the data. One is mean substitution, another one is hard duck imputation and regression imputation and multiple imputation. And these are all various simple methods available. Except the multiple imputation, other methods are easily doable. The multiple imputation is based on a rigorous method called expectation and maximization algorithm, which is supposed to be the state-of-the-art method. Today we have AI methods to estimate imputations. Let me explain what is mean imputation, mean substitution, hard duck imputation. Common traditional method is just, he also said, just remove that observation. So try to remove the observation completely from the data, then you lose number of observations, number of subjects getting involved in the study. What we are saying is a couple of observations are missing, not available, just drop the topic and move ahead with the analysis. And pairwise deletion is similar, that you don't drop the case, but you remove pair two observations consecutive to each other. Deletion method assumes the missing completely at random mechanism and we will yield bias under MAR and NMAR method. So deletion methods. Now the question is that we are not interested in deleting the cases. We are trying to resolve the issues by imputing that information, which is broadly acceptable. And the question is what amount of information is missing, therefore you wanted to impute matters. We have been discussing about if the information is less than 10%, then you are trying to impute it. If it is 30%, 40%, don't try to impute the method, impute the data, even though you have a sound statistical methods. It is okay for observational studies. If you have 20% missing data, you can do the imputation. This is mean imputation. Say, for an example, if I am 12 years old or 30 years old, whatever, you take the 30 years old subjects and now take the average of their value and substitute that value for the missing person information. Say, for example, the height or weight is missing for a 30-year-old person. How do I know? What do I put in that person's data? This is blank now. So what the mean imputation is take all the 30-year-old subjects in the data, take their mean and substitute it in the missing information. Is that clear? It's called mean imputation. Very simple. And this is the last observation carried forward as we discussed it in the morning, especially when you have a follow-up information. That take the previous information and substitute it in the information where it is missing. Now, this is commonly used by CROs when you have a longitudinal data analysis. Researchers mistakenly believe that LOCF weights conservative estimates. Now, there are better methods available. Therefore, we would like to use this kind of methods. There are studies to prove which that I said multiple imputation is a very good, a gold standard method based on simulations, etc. You can also do this exercise. And this is regression imputation. Regression imputation is, we said, say for example, a 30-year-old person weight was missing. So then you look at, you wanted to see if he is a 30-year-old person who is a male and who had diabetes mellitus. I wanted to look at them separately. So therefore, what you do is you do a regression method, taking these as a covariates and predict what would be the value if someone is 30 years old and has DM, diabetes mellitus, and he is a male. Then substitute these values, you predict the values and substitute that value in the missing data. Is that clear? So you do a regression method to do this imputation. This is doable by anybody. This is the hard duck imputation is that impute the missing values with the scores from similar respondents. Okay. So this method involves filling in missing data on variables of interest from non-respondents using observed values from respondents within the same survey data set. So this is identifying that same person is a difficult process when you have large volume of data. So you have to put a lot of if conditions to select those patients. I would go for regression method in such a situations. This is basically, this method difficult to handle in longitudinal studies. This is similar person, similar is the word, which is very difficult to look at. And we need to start the day. This is a process involved in how do we do that one and see. Multiple imputation is the state-of-the-art method which we use for multiple imputation. And recently we developed code for using AI to impute. This is using a random forest model, random forest algorithm. This is, we will polish it and we will put it in our website so other people can use it. So multiple imputation is a statistical procedure. This is meant for, then what we have done is that we have identified this as the best method, recommended as the best method in literature. That algorithm is available in SPSS as well, so very easily you can use it. And it uses random number generations. There's a lot of procedures available. I'm not going into the detail. I wanted to know how could I use this method to impute, fill the holes in the data. Okay, this is imputation, impute the missing entries in incomplete data set, not once, but m times, 5 times, usually 3 to 5 times. We use this for 5 times. Imputed values are drawn for a distribution that can be different for each missing entry. The steps are incomplete data sets. So it generates 5 data sets. I'll show you the flow chart of that concept. This is what it does. There are 5 times multiple imputation that it generates 5 imputed data, and it does that analysis each time and then put that information into the overall data set. This is what finally which we use to use this, the final data into our analysis, which is completely imputed. So this is multiple imputation. The advantage is that it can produce unbiased estimates with the correct confidence interval with a low number of imputed data sets. So we don't suggest, so maximum number of imputation methods which you have is 5, recommended is 5. And lower number, which is 3 to 5, has been recommended here. So I have used 5 methods, 5 data sets, 5 imputations for, I was helping NACO, National AIDS Control Organization, for the surveillance data. The surveillance data had a lot of missing observations. So therefore, we were helping NACO to impute data using this method. So I was asked to train them how to do it and so on and so forth. So we have done that. These are all the screenshots which are available. We will give it to you that you can use in SPSS if you have. There's another method which we have found now, we have developed now using random forest, which Marimuthu developed. We worked together and come out with some algorithms. AI methods. Basically, it's AI-driven algorithm. Random forest is one of the many algorithms which we have. Basically, it does a lot of simulations, bootstrapping kind of concept, which estimate the missing values, which is, we thought it should be better than the MI algorithm, but we have not done any simulation studies to prove that one. So that is all I have to say. I would not look at whether I am dealing with the MAR, MCAR, and so on and so forth. If there is a data, I would like to go by what is the percentage of missing in my data. Is it less than 10%? Then I would like to impute the data. When I'm ready to impute the data, how do I do it? So then I must know the technique to do that one. Either I would use regression method or MI imputation. So the MI is available in every software, even in Stata, and multiple imputation is available in SPSS. I would use it. I would not even look at whether the imputation was missing value was, this is the cost for the missing values and so on and so forth, which I won't like to do that one. So do you have any questions? So what I wanted to tell you is that the MI is the best method. If you are okay with doing a regression analysis and use the predicted values, substitute, fill the holes there. Yes.